Next, I call upon Dr. Manju, a glaucoma surgeon from Arya IK Thrissur, on her topic, role of visual field analysis in detection of glaucoma progression. Over to you, Manju.
Good morning. The tracking of glaucoma progression, a deep dive into the visual field analysis. Let's start with the basic question. What is glaucoma? It's not working. What is glaucoma? Glaucoma is defined as a disturbance in the structural or functional integrity of the optic nerve that can be arrested or diminished by adequate lowering of IOP. So in glaucoma, there is a chance of a progressive optic neuropathy. So the goal of any glaucoma consultant or glaucoma physician is to detect and manage glaucoma progression. So how to detect progression? It's by the structural or functional analysis of the glaucoma. Structural analysis is done by the optic nerve head analysis and OCT analysis, which is already covered, and the functional analysis is by the visual field analysis. So as a normal visual field is defined by the trachea as a hill island of vision surrounded by a sea of darkness. It's around 60 degrees superiorly and nasally, 70 degree inferiorly and 100 degree temporally. And blind spot is a physiological absolute sclerotoma, that is 10 to 15 degree temporal to fixation. And there is a frequency of seeing curve. Basically what is threshold is intensity of the stimulus, which when presented at a particular location n number of times is detected at least 50% of the time, and that is the threshold. And perimetry is basically the systematic measurement of the visual field, and we use usually standard automatic perimetry or white on white perimetry, that is most commonly used, and that is a static perimetry. And we use normally CETA setting that uses prior distributions of normal and glaucomatous visual field behavior to estimate threshold sensitivity. And the usual parameters that is used is a Simulus 3 white with a fixation target central, that is a usually used testing program. And there are testing programs like 30-2, which uses 76 points 6 degrees apart. 24-2, which is usually used in glaucoma, involves 54 points 6 degrees apart. And 10-2, 68 points 2 degrees apart, and the macular threshold 16 points, that is 2 degrees apart. And there are other testing programs like 24-2, which involves an additional 10 test points, that is at the central 10 degrees, which can gives early involvement of central points. So according to these are the Anderson criteria. There are two important points regarding the Anderson criteria. It considers only the non-edge points, but in case of if you are taking 24-2, we have to involve edge points also. And also it should be done or analyzed in 2 consecutive fields. So there are some scotomas that is usually seen in glaucoma. One is a paracentral scotoma if it involves central 10 degrees. Nasal step, which is usually a early involvement, that is a relative depression of one horizontal hemisphere. Then there is arcuate scotoma or Jerem scotoma. And threat to fixation that happens in advanced glaucomas if there is any one of the central points in a 24-2 field is involved. If there is any threat to fixation, it's better to do a 10-2 field to see whether there is any involvement of fixation, that is if one of the central points in 10-2 is involved. And also if there is a threat to fixation, it's important to do macular program to see whether there is any macular split. If there is 2 out of 4 central points with a sensitivity of 0 decibel, or if all the 4 points in one quadrant have a 0 sensitivity, 0 decibel, sensitivity of 0 decibel, you say that there is a macular split. That's most commonly done before any glaucoma surgeries. And see for any artifacts. One is a rim artifact, usually due to the correction that is given during the field testing. And there is chance of high positivity. If the patient is a trigger happy patient, you can have high false positive reports with white scotomas, and the lethargic patient may give a high false negative or a clover leaf pattern kind of fields. So see for any artifacts. And most important, before detecting any progression or analyzing for a progression, important to have a structure function correlation. Like you have to take the structural, that is OCT, and see whether your field report corresponds to that of the OCT, to see whether there is any there is structural function, proper structural function correlation. As in this case, the OCT analysis is both the eyes are normal, but there it shows a field defect. So when we repeated the field, this patient didn't have any field defect in the left eye. So it's important to have see whether the patient is having correct structure function correlation. And same as in this case, it gives a full report where this is the patient's disc photo, and this is the RNFL defect, and this is the ganglion cell complex analysis. So the machine itself predicts that if the patient is having an RNFL defect in this region, where can be the field defect in this patient. So if there is an RNFL defect in this region, there can be a field defect in this region, the machine is predicting. So we are doing the visual field analysis in the HFA machine, and as the machine predicted, the patient is having a field defect in the same location. So there is a good structure and function correlation in this patient. Now coming to the progression analysis. So what is basically progression? There can be a deepening of scotoma, enlargement of the existing scotomas, and appearance of newer scotomas. So many prerequisite for the guided progression analysis, which was almost similar to that of the OCT analysis, there should be a baseline visual field testing, and it should be better, preferably post-learning curve. The patient can have some learning curve. So if the baseline reports are post the learning curve, it's better. And there should be a consistent testing condition. If you are testing the patient in one condition, it should be tested, all the fields should be tested in the same condition, and reliable, the data should be very reliable, and regular testing schedule, at least 5 testing schedules should be within the 2 years if possible, and patient cooperation and compliance is very important in this case. So this is the guided progression analysis given by the machine. There should be a minimum 5 fields, same as OCT. There are 2 baseline field and 3 follow-up field, and the report will have the 2 baseline field in the upper part, and this is the current field, and the machine will itself give the trend analysis, like if the patient is having the same rate of progression, what can be the patient condition after 5 years. That is the trend analysis that is given by the machine. This is the rate of progression of the patient. So these are the visual field index is there, mean deviation is there, all it is written, and you can have progression analysis either by the visual field index or the mean deviation, and the visual field index of all the visits will be recorded, and the machine can extrapolate this data over 5 years and tell us that if the patient is having the same rate of progression over 5 years, what can be the patient's visual field index after 5 years. So it can tell you whether you need more intervention at this point of time. So that is what is called a trend analysis based on visual field index, or can be based on mean deviation also, to quantify any observed rate of change and to assess the risk of future visual disability. That is the most important one. Can give the risk of future visual disability if this rate of progression is the patient is having the same rate of progression. So what will happen over 5 years if the current rate of progression continues? So this patient was had taken the first visual field and second visual field, and the patient lost follow-up for some years, and now this is the patient's visual field. So if you extrapolate the data over the 5 years, the patient is going to go blind. It's almost 0. So if the same rate of progression is happening to the patient over 5 years, the patient is going to become blind. So it's the patient machine or the program is practically telling you need to do some intervention, either increase your medication, do a laser or surgery. You need to do some intervention to reduce the rate of progression at this point so that the vision can be preserved for the patient. Almost the same, and there is one more thing. If you change your management protocol, or if you do some trabeculectomy, or if you do some glaucoma surgeries or laser procedures, you need to change the baseline field after that. So Here the patient was having this rate of progression here, and then a surgery was done. Now we have changed the visual field, I mean baseline visual fields. Now these new, after the surgery, the first visual field that we take will be taken as the first baseline visual field, and then after the procedure, what is the rate of progression? That's what next we will calculate. So if you do any intervention, you have to change the baseline visual field after that. There is also event analysis to assess whether there has been a significant worsening from the last field or from the baseline field compared to, that is, event analysis is in comparison to the stable glaucoma patient. So if there is any 5% deterioration, it will be given as an open triangle. And in the next, or the consecutive field, there is again a 5% deterioration, you will have a half-filled triangle. And in 3 consecutive fields, you are having a 5% deterioration, you will have a full-filled triangle. So if there is a, if you cannot, after that, if there is any progression, it's out of the range, or the machine cannot calculate the progression after that. But there is one thing, it should be consecutive field. If you don't have a progression in the next field, it will again go into the first open triangle. So, and based on this, the machine can give you reports like possible progression. If same point, there is deterioration in the same point in 3 consecutive visits, significant deterioration, sorry, in 2 consecutive visits is possible progression, and 3 consecutive visits, if there is a deterioration at the same point, it's like a likely progression. So here in this patient, at this point, there is an open triangle, this is a half-filled triangle, and there is a full-filled triangle. So the patient is having a same deterioration at the same point in 3 visits. So there is a possible progression, and second is a likely progression. So event analysis is important that you should have a consecutive fields. And there should be at least 5 fields. So if you have only 4 fields, there is only, you can't get that extrapolated data, but by looking at this, you can see that there is a decrease in the visual field index. It was like here, and now in the follow-up visit, the patient's VFI has reduced. So, but only if you have 5 fields, you will get the extrapolated data. And there is, according event analysis, you can have reports like likely progression. And there can be a learning effect. In this patient, the final visual field is better than the previous one. It can be due to learning effect. So it's better to negate learning effect before taking the baseline visual field. And in patients with advanced field effect, it's always better to do a 10-2 field. So the future dimensions are, there are AI or ML algorithm which can detect even subtle pattern and give you early signs of progression. And there are data collected from the visual field, OCT, Octa, and even genetic information that can increase the accuracy of this diagnosis. And there are many longitudinal studies that are going on regarding the tracking pathogens and progression, which may help us to have a personalized or tailored treatment plan for our patients. So the take-home messages are OCT and visual field are complementary diagnostic tool. Early detection, which helps in the early detection and monitoring, and to calculate rate of progression and to plan early intervention. But there can be an individual variability, and clinical correlation with other factors are important. Thank you.
Thank you, Dr. Manju, for simplifying such a complex topic.